Let's understand few points on pathophysiology of rheumatoid arthritis. So consider this is a blood vessel. This is a blood vessel, and here is one of the cell of the body. So what happens is normally there is presence of protein production inside the cell. So if there is abnormal protein production, or if there is a misfolding of protein production, what happens normally is abnormal protein or cells engulfed by the macrophages and clear. But what happens in rheumatoid arthritis is presence of risk factors or predisposing factors make this cell to produce a protein, that is DNA, DNA to RNA, RNA to protein, that is transcription, translation, and after the production of an protein there is a post-translation modification. Post-translation modification. These risk factors or predisposing risk factors make the post-translation modification. One of them is citrulline. Citrulline. What happens in citrulline is this protein chain abnormally there is presence of arginine in between the chain. Arginine in between the chain. So this is known as citrulinization. Abnormal arginine fixation inside a protein by post-translation modification because of presence of risk factors is known as citrulinization, or simply it is a citrulline protein. So even though with this happens, there is chance of a macrophage clearing this cell, but here in this individual there is presence of abnormal HLA-DR1 gene. This abnormal HLA-DR1 gene makes the macrophage, instead of phagolysosoming an abnormal cell, it mounts an immune response against this protein. So it stimulates T cells, that is specifically CD4 cells, inside a lymph node. These CD4 cells make stimulation of B cells, and these B cells secrete antibodies against the protein citrulline wherever it is present in the body. So this abnormal antibody production against this citrulline antibody makes the spectrum of clinical manifestations in rheumatoid arthritis. So one of the important aspect here is, consider this is one of the bone. As you know, bone is protected by one fibrous cartilage, and if this bone protected by one capsule, it is known as synovial joint. Okay, so predominant citrullization or predominant citrulline protein will be occurring in our body here in type 2 collagen or vimentin. Type 2 collagen and vimentin. So this type 2 collagen is present in fibrous cartilage over the bone in the joint. So this is attacked by this antibody continuously. So inside a joint there is antigen antibody production which calls for complement proteins. So these complement proteins again destroy the tissue, destroy the joint, making the bare bone opening inside the joint cavity. So what happens is this abnormal or stimulated T cells now come into the picture, and these stimulated T cells have a rank ligand stimulation. This rank ligand stimulation over a destroyed fibrous cartilage activates osteoclast. This osteoclast eats up the bone. This osteoclast activated eats up the bone, leading to bony erosions. So what happens inside a joint cavity now? There is presence of antigen antibody and there is presence of T cells. So these T cells inside the joint tissue secrete interleukin 17 and interferon gamma. This interferon gamma again recruits many macrophages. This macrophage inside a abnormally joint tissue, it secretes interleukin 1, interleukin 6, and TNF alpha. So now what happened is, inside the joint tissue there are active players, antibody activated T cells stimulating the osteoclast by rank ligand, and there is a activated macrophage secreting interleukin 1, interleukin 6, and tumor necrosis factor alpha. These now enter systemic circulation. Systemic circulation, that is here. So this entry of systemic circulation continues, there is a continuous source of this interleukin 1, interleukin 6, and these three things inside a systemic circulation leading to extra articular manifestations such as lungs, heart, etc. So only tissue which is spared by this is CNS. So in rheumatoid arthritis, CNS is rarely involved. Only thing causing is presence of interleukin 1 leads to fever. That's it. Rest all, most of the changes are present in lungs, pleura, heart, pericardium, etc. So in this, the treatment is completely based on this pathology only. First line of treatment is always DMRD. There are 3 DMRDs, that is methotrexate, sulfasalazine, and hydroxychloroquine. So apart from that, we need to inhibit all these active players, that is interleukin 1, interleukin 6, TNF alpha inhibitors, interleukin 17 inhibitors, and T cell inhibitors and B cell inhibitors. So this is the pharmacological therapy to treat, and if we inhibit all these things, that is known as biologicals. Few examples are inhibition of T cells by abatacept and TNF alpha infliximab, etanercept, etc. So this is a fair short pathological changes in rheumatoid arthritis. Thank you.